Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Good morning. My name is Noah Ferziger. I am a student at the Albert Einstein College of Medicine, and I'm here with our guests, Dr. Melissa Lodano and Dr. Nithya Abraham today. Could you please introduce yourselves?
Yes, good morning, Noah. Thanks for having us. My name is Nithya Abraham. I'm professor of urology and OBGYN at Montefiore Medical Center. A little bit about me. I did my urology training at NYU and a 2-year fellowship in URPS at Cleveland Clinic, and then joined here at Montefiore in 2015 and have been here since. I'm currently serving as the director of the Urogynecology division.
Thank you so much.
Hi, everyone. Hi, Noah. Thank you for having us. I'm Melissa Lodano. I'm an associate professor of urology and OBGYN here at Montefiore Einstein. I did my urology training at New York Presbyterian at Cornell, and then was an URPS fellow here at Montefiore, and then stayed on as faculty starting in 2017. I also recently took a role in the medical college at Einstein as Assistant Dean of Clinical Education, and am our URPS Fellowship Program Director.
Thank you so much. Actually, I didn't realize, Dr. Lodano, that you trained here too. That's awesome. So as you guys know, we're here just to hear a little bit more about FPMRS, urogynecology. So could you each share a little bit about how you decided to do that fellowship?
Yeah, so in residency, we had a clinic at our city hospital that the residents saw all the patients. And every time I had a female patient, they would be so relieved that I was a doctor taking care of them. And that kept happening over and over again. And then I started wondering, well, maybe I should just focus on taking care of women. And so then I started exploring URPS as a subspecialty. And I had mentors at NYU, Victor Nitti, Nurit Rosenblum, really great mentors who got me excited about the field. And so I thought, I want to subspecialize in this, and applied for fellowship, loved my fellowship. And I really enjoy what I do now. So I'm so happy that I pursued it. What about you, Melissa?
A pretty similar story. I think when I started medical school, I thought I wanted to be a cardiologist, which obviously this is pretty far from that. But
I just want to say the heart and the brain, and the heart and the bladder are pretty similar.
Yeah, plumbing. But anyway, I did a rotation in between my first and second year in medical school, where I did research and worked in a women's health focused on cardiology clinic. And I quickly realized that the medicine route was not exactly what I was looking for, but I loved the women's health part of things. And so I kind of always had that in my mind. And then when I was a medical student, we did have the good fortune of doing a mandatory rotation in urology. So during that rotation, I met someone that did female pelvic medicine, and I thought, oh wow, this is amazing what she's doing. And so here I am.
That's awesome. Yeah, I mean, I've enjoyed working in both of your clinics. So could you tell us a little bit about what, I guess, a typical clinic day looks like, a typical OR day? What are the bread and butter cases?
Sure. Yeah. So clinic is a lot of evaluations of new patients coming in with urinary leakage, feeling a vaginal bulge, or people who are referred from other institutions because of complications from other surgeries or incidental imaging findings like diverticulum. And so our OR cases then are treating a lot of those conditions. So our ambulatory surgery days, we're doing cases like, for example, later today, I'm going to be doing a midurethral sling for stress incontinence, neuromodulation for overactive bladder, and then I happen to throw in a stone case too. So we still preserve some of our general urology training.
Yes. And I think, the nice thing about our specialty is that there's a lot of diversity in the conditions that we treat and the procedures that we do. There's robotic surgery that's a part of things. There's, like we were saying, there's office procedures, and then there's ambulatory cases. So really the whole spectrum of surgeries that we can offer to our patients. And I do think also I really love our team. We're part of a large team in our clinic. So we have nurse practitioners that support our patients. We work closely with like pelvic floor physical therapists. So there is a very like multidisciplinary feel to our specialty that I really enjoy.
Yeah, speaking of the diversity of cases, I think, if you want to do really complex cases, you can do robotic prolapse surgery. You can do robotic reconstruction, like reimplants or fistula repairs. You can do urinary diversions or bladder augments. But if you also want to just have more of an office-based procedure, especially when you take on more administrative roles, and a lot of people in our field, when they become assistant dean or CMO, or they have more demanding administrative roles, you still can have a busy office-based practice or ambulatory surgery practice. So it's really nice to have that spectrum of opportunity that you can still be really active in the field.
Thank you. So you also touched on something I was curious to hear more about. You mentioned that you also still do some stones and some general urology cases. So how do you decide, or how do those cases, how do you choose? Yeah, what's your division of, FPM or F specific versus general urology?
I think one thing we've talked about this. I think, both of us still take general urology call here, and we like that. In that, I mean, obviously call can always be a bit of a burden, but it's also, there are a lot of benefits to it, and we recognize that. So I do think it's nice to maintain your roots in general urology. And also it keeps us very connected to the program at large. So we're connected to the urology residents. And then I think once as your practice evolves, like Dr. Abraham was saying, then you can, there are some times where we'll take care of something when it comes in on call, but if it's a very large stone and they need a PCNL, that might be something that we refer over to our stone endourology specialists, and they're happy to take over the care of that patient for further management. And everyone's threshold is different, and that's fine, and something that I think also we like about our specialty, and also the collegiality of our department.
Yeah, I think any complex cases I'm definitely sending to my colleagues. But being able to do just simple stone cases, stents, whatever else it may be that comes in while we're on call, keeps us, still fresh with general urology. And I think that's a strength that we have. If we were to go somewhere else in the country, we have general urology skills that we can bring to the table, but we also have IRPs, subspecialty skills that we can bring to the table. So I think that makes us even more attractive out there if we're looking for a different role, that we bring two important sets of skills to an institution. And so I'm grateful that I have that, I think it makes us more attractive for those who are looking to hire urologists.
Definitely.
Thank you.
A plug for us getting more urology residents to come into our fellowship program.
Yeah, which, congratulations, a successful match yesterday.
Yes, we were very excited to match two, one OBGYN resident and one urology resident, which I think it also highlights a really nice part of our field, that like overlap or intersection between those two departments is so sort of key to what we do and maintaining that close relationship. And our fellows love teaching each other, and having people from both of those different sides of training, I think really makes our field special.
Yeah, it is pretty unique, especially here, how collaborative we are between the two departments. And I feel like, very involved in both departments, in urology and OBGYN. So I think that's another highlight of our subspecialty, is that you are a valuable asset to urology and OBGYN. And Interestingly, across the country, there are some urologists who've even been hired into OBGYN departments. And I don't think there's any other subspecialty within urology that offers that kind of multidisciplinary collaborative opportunity.
Just for a little bit of background, could you explain the difference? Let's say a student is interested in urogynecology. Could you talk about the training route of going the OBGYN route versus the urology route?
That's a really good question. I think that, one thing to note is because there is so much overlap in the end goal, I think oftentimes the end result is very similar. It's more the path that you took to get there. And so I sort of explain it to students, at least from my perspective, is like, you do have to figure like out what you like to, I say dabble, but it's not really dabble because it's a residency program. But what do you like to have in your practice that's on the outside of the core herbs training that you'll get? So for some people, they really love the OB portion of things, and they don't mind that they're going to spend a fair amount of their residency on the labor and delivery floor. And there are other people who really enjoy still taking care of male patients and doing male voiding dysfunction and stones and other bread and butter urology cases. And so I think kind of knowing yourself and deciding where do you want that the outskirts of your training to be is the main question. And once you decide that, I do think that you can end in the same place from either route.
You know how I knew the OBGYN route was not for me? When I was a medical student at witnessing the first vaginal delivery, I was so overwhelmed by all the fluids and the unpredictability, the messiness that I fainted. I went into the hallway and fainted, and the resident had to come bring smelling salts to wake me up. And I thought, okay, this is how I know this is not the field for me.
So you want just urine, no other liquid.
Sometimes those things, even though they feel uncomfortable when you're a student, though, it's in a way, it's a blessing because then you know that up front and it helps you make important decisions. So you've got to pay attention to your
what your body is telling you.
Your body is telling you.
But going the urology route, I do appreciate taking care of men as well. And so we still have male patients with voiding dysfunction, refractory overactive bladder. And so going through the urology route, we're able to take care of both men and women with complex incontinence and voiding dysfunction, which you wouldn't have that opportunity if you went the OBGYN route.
I do also, to that point, I really do enjoy some of the neurourology portions of our field, and not that you can also do that as an OBGYN who's trained in ARPS, but I think that there is a lot of our training for both of us in residency and then in fellowship did have that background. And I do think that's a subset of patients that sometimes can really, they really do need subspecialists who are dedicated to caring for that patient population. So
yeah, you're so right. We're a lot more comfortable taking care of patients with multiple sclerosis and spinal cord injury, just because we've already seen those patients even as residents.
Exactly.
That's awesome. I'm doing research this year with a spina bifida population. So I've been thinking about this a lot. Do you end up with patients, I guess, with spina bifida in your clinic?
So we have worked closely with our pediatric urology colleagues to work on this transition of care that happens for patients who have been, often in the pediatric urology practice for their whole lives. And then as they transition into adolescence or adulthood, need specialists to take care of them. So that is definitely a part of our practice. And I do think it's nice to have that close relationship with your pediatric colleagues in caring for those patients.
And another aspect that's just related to this is we get to enjoy continuity with our patients. And when you mentioned spina bifida, I was thinking I have several patients with spina bifida who see me every 3 to 6 months for their bladder Botox injections. And so we get to do these complex surgeries, but we also get to just do bread and butter things like Botox injection and have continuity with patients who see us for years.
Yeah, the continuity is another really nice part of our field that I think is often part of what drew people to urology in the first place, and certainly is something that continues in our field.
That sounds really nice. Do you have favorite cases to take care of?
Oh, good question. I like that. So I do love doing sacral neuromodulation cases. I love the juxtaposition of operating and using fluoroscopy or x-ray in those cases. I think it's kind of like a bit of a puzzle to figure out, and I enjoy doing those. I also really like a sling case.
I was
Dr.
also
Dr. O'Donnell, just for the students listening, do you think you could explain what sacral neuromodulation is?
Sure. So this is one of our more advanced therapies that we use for overactive bladder or urinary incontinence. And it's basically, we often say to patients, it's sort of like a pacemaker for your bladder, which is possibly a
Back to the
simplified
cardiology.
version. Back to cardiology.
yeah,
Yes.
back to cardiology.
I knew I could get that in there somewhere. So we are putting a small electrode to the sacral nerves, to the S3 foramen, and attaching it to a small battery that is all implanted under the skin. And in stimulating those nerves, we can kind of pass their action potential so that they're not firing so frequently on their own, and it helps us to control that frequency of urination accidents that are associated with urge incontinence.
Wow.
You want to do
Dr. Abraham, what about you? What are your
So
favorite
I have several answers, but
Yeah.
okay, sling
Sling
is one of my favorites because of how well patients do after surgery and how happy they are that they're
Yes.
no longer leaking, that they can wear regular underwear. I've had plenty of patients hug me afterwards because they're just so
Aw.
happy that they're no longer leaking, and so that's really rewarding. I also like urethral diverticulectomy surgery because it's just, you have to do all this careful dissection to shell out the diverticulum, then
Yeah.
repair the urethra, and so just the reconstructive aspect of it is really fun.
I think also, yeah, that one is another one that I enjoy, in that every case is different.
Right.
You never know what you're going to expect, and it does have, for those either medical students or residents that are listening that are interested maybe in plastic surgery, it does
Yeah.
have that kind of a feel to it, that
Mhm.
you are, doing very fine dissection, and also thinking about in the moment, how am I going to fix this? Because you can never plan exactly what you're going to do.
So true. There's a lot of creativity in how you create the flaps and then reconstruct everything. And then one more that I'm going to add in there is I also really enjoy doing vaginal hysterectomy and prolapse repair. I think every time that I do it, I'm still intrigued at the end that I just pulled an organ out through the vagina, and then I then put stitches to resuspend the vagina, and then
so minimally invasive, right?
exactly. Minimally, I don't even need a robot. Minimally invasive, and she looks like a new woman. So it's amazing the different approaches we can take to accomplish the same, prolapse repair.
Yeah, Dr. Abraham, I'll always remember one time in your clinic you were mentioning how patients will hug you after their surgeries. There was a woman who came in, I think she was in her 60s or 70s post-surgery, and she was like, I'm going to see my grandchildren again. I used to not leave my house. And it was just like such a life-changing event for her.
Yeah, I think that's what makes our field so great. It's challenging managing quality of life issues because you can't cure everybody and you have to manage expectations. But in those moments when you do really fix something and it dramatically changes their lifestyle, it's so rewarding.
Absolutely. And I do think that, having that, the breadth of experiences that we see in the operating room is really what, like, having those moments afterwards is really what fuels you to be able to do all of the, to deal with all of the challenges that we deal with in medicine. It really does make it all worthwhile when you have those moments.
Definitely.
Yeah, Dr. Abram, you mentioned that sometimes it can be challenging to manage the quality of life issues. What did you mean by that?
Well, I think sometimes people want to be dry, for example, if they're having leakage problems. And for some people, it's just that's not going to be feasible if you have mobility issues and you just can't physically reach to the bathroom in time,
Yeah.
Or you're frail, or diabetes is not well controlled. There's only so much we can do, and so in that regard, sometimes it can be challenging for a patient to have to accept that they're we can improve things to a certain point, but we can't necessarily cure everyone. And that's where patient counseling is so important in our clinic, talking about, what are the things that patients can do, what are the things that we can do, and then also what are the things that may not be changeable.
Yeah, I think that I agree. I think sometimes one difficult condition that we manage is patients who have chronic, either Foley catheters, suprapubic tubes, or are on CIC, clean intermittent catheterization, and have urinary retention. I do think for those of us out there who are listening that, if we could find a way to fix them, they would, talking to some of those patients about having a chronic lifelong condition where they're going to be catheter dependent in some form, it can be really hard for patients. And so sometimes when I think about having those discussions, you do see like how these things can have a profound effect on patients. And if you can't quote unquote fix it completely, it can be a really hard thing for patients to wrap their brain around.
Mm-hmm.
But so I think, we do often have to have some challenging conversations with patients.
Mm-hmm.
Thank you. And how do you, I guess, feel after those conversations?
Oh, I had one yesterday. I think, I think it can be, I mean, you said, how do we feel? And I appreciate that question because there is so much of taking care of patients. Like some of it does kind of go onto you as well.
Mm-hmm.
And those can be really hard and draining conversations to have with patients. But I think also to be able to really like set realistic expectations, but leaving them with at least the hope that you are going to be a partner in taking
Mm-hmm.
care of them, and you're not going anywhere, and you're going to be there for them. And even though it may not be perfect, or that there's this magic cure, you're going to be with them as they kind of walk this journey medically. And I think that in creating that space, it can be challenging and a little bit emotionally draining for us, but also I think it does feel rewarding still. And I think it seems that patients really are grateful to have that relationship.
Yeah, totally agree. I think that honesty is key, right? And so if patients feel like you're being honest, you're doing the best that you can, I think they understand and appreciate that.
Mm-hmm.
Yeah. Sounds like difficult conversations. So thank you for that insight. I know we have to wrap up in a few minutes, but I just wanted to ask a few more general questions. So one, for students rotating through maybe a urogynecology week or rotation, do you have any advice for them? What should they look out for? What should they, I guess, try to look into?
Oh, I guess this is more of a general tip for students rotating, but I think really be proactive, get in there as best that you can to really make your experience hands-on. And that can take many forms in our clinic. So I see, our students who are really engaged. We've talked about how like as soon as you walk in the room, grab a pair of gloves because you really can't do anything if you're in a patient room if you don't have a pair of gloves on. So that just gets you in the mindset that you're going to be there to do.
Mm-hmm. Mm-hmm. And to help, yeah. And even just stepping back one step further is there are a lot of urology programs that don't have a strong urogynecology subsection. And so as a student, I would seek out programs that have that diversity and subspecialization, because otherwise you may not even get exposure to urogynecology.
Good point.
And so you want to find those programs that have herb specialists there especially for residency training. I think it's an important skill to learn, and so you want to find a program that has herbs.
Yeah, I know your department's relatively large with a couple of attendings, but what is the standard size of a urogynecology clinic?
Oh, that's a good question. I don't know that there is necessarily a standard.
Yeah, I mean, there are some programs out there that don't have herb specialists because it's challenging to find urologists with our subspecialization. And so often they get, residents get that exposure maybe with rotating through the OBGYN department or with maybe adjunct faculty. But our program is quite large in the sense that we have 3 people subspecialized in herbs. We have a 4th person joining in September, and we're already looking to hire our next person. So we just keep
Wow.
We're growing.
So you'll get a
wow
experience here.
Wow. And can you talk a little bit about either, I guess, 2 things. One, I know you're each involved in research, what your research is, and then 2, just some general trends in the field that are exciting you these days.
Yeah, I think because of where we work in the Bronx, a lot of my research has been looking at unmet social needs or social determinants of health and how that impacts pelvic floor disorders or urogynecologic issues. And we have found that overactive bladder is more severe in those patients with unmet social needs. And so if we can address some of those issues, like for example, if it's a transportation issue and they can't get to their appointments, then often for many of their medical problems, they're more severe. And so that's one aspect of the research that we've been looking at. But then we've also been doing a lot of quality improvement research. You have a project going on right now.
Yes, we are doing a project to look at pain control, peri-procedural pain control for Botox injections. So sort of traditionally in our clinic, we've done an installation of like a lidocaine mixture for, 20 to 30 minutes before they get a Botox injection. And that can be time consuming for our clinic workflow and also for patients that are coming in. So we are looking at that versus using a dose of Peridium, a pill that they would take orally before coming to the clinic, and looking at how that affects their pain control and also just general satisfaction with the flow of the visit. So, and then, one other thing to highlight at our about research here in our division, we do have a PhD on faculty for urology, Dr. Sylvia Sudakani, who does benign bladder dysfunction research. And I think we're so fortunate to have her. Our fellows are fortunate. So we've actually, both of us have collaborated with her for years to look at sort of translational research opportunities. So sort of this idea of like a bench to the bedside approach. And it really does, I think, our fellowship has been, our fellows have been very fruitful, spending some time in the basic science lab. And that was never something that I necessarily thought would be a part of my career. And I think it's been really valuable to have that relationship as well.
Yeah, I think that's an advantage of then doing fellowship training in herbs, is you get to be involved in all these different types of research projects, whether it's quality improvement, translational research, or just studying the local community to improve care for them. It's an opportunity to take some dedicated time to just learn the art of the surgery in herbs, but also to do research. And so I think it's a really fun 1 to 2 years that's different from what you do during residency.
Wow. Yeah, I mean, it sounds like you have a really large flourishing clinic. And can you talk a little bit about, I guess, what's up and coming in the field? What's an interesting paper you read recently, or what do you think what are things gonna look like in 5 or 10 years?
Up and coming, I mean, I was just commenting to Dr. Lodano that I can't believe we operate in the leg now. because the technology is advanced for the management of overactive bladder. And so one of the newest devices on the market is an implantable tibial nerve device to control overactive bladder. And so now we both operate in the leg to implant these devices. And so I think the field keeps evolving,
Yes.
and that involves us evolving as well to learn to pick up these new skills and new techniques in certain ways. But I think that also keeps the field exciting for us.
Absolutely. I do think that that is a great example of just being open to learning new surgical techniques, approaches, to staying, as a lifelong learner, to staying current and going to courses. And I do think that that is something that keeps us engaged and excited about our field. So yeah.
Yeah, and so we both do robotic surgery, and so the OBGYN department just recently invited us to try out a new robot, and so we're also expanding as far as the technology we use to do the surgeries that we've already been doing, but to enhance how we do those surgeries. So there's just so many new exciting things coming in IRBs.
Well, thank you both so much. I've learned a lot. I've really enjoyed this. So really, thank you both for coming on this podcast.
Thank you, Noah. This was so much fun.
Yeah, thank you for having us. And if there are any medical students out there who have questions about IRBs, we're both available.
Yes, absolutely.
This has been an AUA News Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.